Our next speaker will be Marc Priest. He'll be representing Spectrum Medical. Marc has started his career as a critical care RN, but also moved on into programming and now leads a clinical sales team and also an informatic associate supporting Spectrum Medical Solutions. Thank you so much.
Happy Perfusion Week, everybody. So I think we forgot about that at Sanibel, but it is, it's a little bit late end of the Perfusion Week, but happy Perfusion Week to all my perfusion colleagues out there. Today I'm going to talk to you about hypobaric oxygenation in our hybrid system. Full disclosures, I'm not a perfusionist, as Luke mentioned, that my background was as a critical care nurse, but I appreciate the perfusion community accepting me for my role in their life. I also work for Spectrum Medical. Just to start off, we're going to talk about the pathophysiology of gaseous microemboli in the body, and we'll discuss the short and long-term effects of gaseous microemboli. We'll mention some of the past techniques designed to remove that gaseous microemboli, and then discuss how Spectrum's solution chose to attack removing gaseous microemboli from our patients. So gaseous microemboli are air bubbles that are introduced into our patient's circulation. They're a pretty common occurrence in both bypass and ECMO. Sources are venous air entrainment, cardiotomy suction, blood sampling, and drug administration, and of course air from the surgical field. Gaseous microemboli by itself can be harmful. It's mostly made up of nitrogen. It's a nitrogen air bubble that kind of circulates through the circulation. It can cause ischemic injuries by blocking blood flow through blood vessels in the brain, contributing to stroke, transient ischemic attacks, delirium, neurologic deficit. It also causes inflammation. So as it's traveling around in the blood, it can increase inflammation in the blood. And protein coatings can form around the GME, stabilizing the bubble. And if it stays in a bubble form, that's when it tends to wreak more havoc, contributing to some post-operative neurologic injury. So going back to people who have looked into the problem for a while, I think it's been relatively well accepted that, when our grandparents have cardiac surgery, sometimes they don't always come out maybe as sharp as they used to be, and we blame it on age and other things. But there is some data that, kind of relates, looking at post-op cardiac surgery patients. Duke, with the documentary from Pumphead, looked at 261 patients and found that 53% of them had a significant cognitive decline post-cardiac surgery, and 42% suffered of it from a year later. Pugsley and his group also looked at high-intensity transcranial signals, or HITs, looking at air, and found a direct correlation that the higher the number of HITs, the higher the percentage of neurologic deficit ensued. Looking at around 200 or less HITs, you had about an 8.6% deficit, and then it's just a kind of linear correlation that as you go up, getting up to over 1,000 HITs, up to as high as a 43% incidence of postoperative neurologic injury. And Groom and his group looked at S100Bs, which is a serum marker of neurologic injury, and also found a direct correlation with gaseous microemboli. The higher the load of gaseous microemboli, the higher the S100B, and the higher the incidence of postoperative neurologic outcome. All right, so we know there's a problem with air in our circulation and air getting to the brain, and we know that can happen with cardiac surgery. So now, just to kind of set the foundation to try to understand hypobaric oxygenation, I want to make sure we're all starting from the same level point of atmospheric pressure, 760 millimeters of mercury, the total partial pressure of all the gases in the blood, right? So as I'm speaking about this, I want you to think about the total partial pressure of gases in the blood, and under normal circumstances, that's 760. So keep 760 in your mind, understanding that up to 78% of that is nitrogen, okay, an inert gas that is not necessarily beneficial in our bodies. And then when you're on bypass, as soon as you start turning that blender down from 100% FiO2, you're immediately starting to add nitrogen in to dilute down the oxygen, right? So there is a percentage there where you're using different amounts of nitrogen in your blended gas to get to the patient. And so when we're talking about a gas bubble, and over here, looking at the total partial pressure of gases that are made up in the blood, you can see nitrogen can take up that 450 to 500 millimeters of mercury, plus 200 gets us up to 700, and maybe another 40 is CO2, getting closer to about 1 atmosphere of total partial pressures in the blood. And then if you have a gas bubble, which is mostly made up of nitrogen, it's going to stay in that bubble form and wreak its havoc because there's no nitrogen gradient. There's a similar amount of nitrogen outside the air bubble as there is in the air bubble, so it stays as an air bubble and it continues on to wreak its havoc. So the question becomes, well, how can we deliver 100% oxygen and not give any nitrogen to our patient, but still make sure our post-oxygenator PaO2 isn't 500 or 600? Okay, that was our goal, to be able to do that in a reproducible manner. And so, the whole philosophy about us trying to achieve a hypobaric state in the circulation was to denitrogenate the blood and to give you guys, the end users, a controllable and reusable way to be able to do that. And so really what we're looking for is no nitrogen, PO2 100 to 150 with CO2 of 40, looking at total partial pressures in the blood to be about, anywhere between 100 and as high as 200 millimeters of mercury, which leaves a lot of space for that nitrogen now to reabsorb back into the fluid state. Okay, so that's the goal that we're trying to achieve. Everybody with me so far? All right, we'll see, we'll have a test later. So also for anybody who endures the rest of these lectures, you can come see us from 4 to 6 in the Blue Heron Room. There will be drinks and food to recover from these academic talks. So, the other thing I want to challenge you guys is about the perils of hyperoxia. Okay, I all know you want a post-oxygenator PO2 250, and you sure feel a lot more comfortable when it's over 200. But I think there's more and more data to show that the higher and the more oxygen we give our patients also contributes to some negative impact. So there can be an increase in oxidative stress due to reactive oxygen species. Stimulates an inflammatory response with pro-inflammatory cytokines, oxidative stress markers, and tissue injury, as well as ischemic reperfusion injury and vasoconstriction. And so inflammation and oxidative stress in the context of extracorporeal and cardiac pulmonary support is an issue, and there are some studies looking at normoxic cardiopulmonary bypass reduces this oxidative myocardial damage and nitric oxide during operations in adult surgery. So I think you're going to see more and more people, looking to see how you can make small improvements in postoperative morbidity, and giving less oxygen is going to be one of those strategies. Gibson and his group, they figured he did a lot of research in this area, and when he first tried to create a hypobaric state, he used suction and vacuum. And by doing so, he was able to prove that, okay, pre-oxy, we have a lot of GMP here. There's a decent amount post-oxy, and then post-arterial filter, it decreases, but still a lot of that gaseous microemboli, or those air bubbles, are getting through to the patient under atmospheric conditions or blended gas conditions. Okay, but if you're able to create a hypobaric state, and in this case, he showed it using vacuum, he was able to show that post-oxy significant decrease. Post-filter, as that blood's traveling down the arterial line towards the patient, you continue to get some reabsorption of those gas bubbles due to the hypobaric effect, so that by the time it gets to the patient, there's little to no gaseous microemboli getting to the patient. And you're not just creating a hypobaric state in your cardiopulmonary circuit, you're creating it in the patient's full circulation. Okay, so you're not giving any nitrogen. You create a nitrogen gradient. That nitrogen is exhausting out of the oxygenator. So the first couple cardiac output cycles, when you go on, you can basically denitrogenate the patient's blood, and then you create a full hypobaric circulation in the patient so that any gas bubbles or gaseous microemboli that are traveling around inside the patient can reabsorb back into the fluid state and not wreak harm into the brain. And so under control, atmospheric conditions, blended gas conditions with nitrogen, you can see this is just a slide of the periventricular white matter where these gaseous microemboli wreak havoc in the capillaries in the brain. And under hypobaric conditions, you can see a lot of that gaseous microemboli is mitigated. Another way to potentially create a situation like this is to use a VA shunt. Just take the oxygenated blood and take some deoxygenated blood and add it to it that doesn't have nitrogen in it, and you can get the PaO2 down to get the total partial pressure of gases down. But the problem with that is, how do you create a system that can reliably reproduce that on a case-by-case basis and on a consistent basis? And so when they created a VA shunt to try to do something similar, they did prove that you get less GME and less gaseous microemboli. So that was another way that they looked at. And so when we looked at those ways, we said, well, I don't think we can do this reliably and comfortably and safely with vacuum. We couldn't think of a way to, adequately create a consistent VA shunt. So we decided to create a dual chamber oxygenator. and to allow you to create a controlled VQ mismatch so that you can use 100% oxygen all the time, no nitrogen, but still be able to keep the post-oxygenator PO2 low and physiologic or normoxic, okay? So, and we do this by separating the two chambers of the oxy. So all the blood goes through all the polypropylene, okay, and circulates through all the fibers, but you're fully ventilating one section of polypropylene fibers while you're selectively underventilating the second half, okay? It's kind of like a lung that has pneumonia. You know, you're not fully ventilating that section of the lung. Well, we're not fully ventilating a section of the oxygenator. Meanwhile, all the blood goes through all the polypropylene. And so by doing so, we allow you to use 100% oxygen, but still be able to keep that post-oxygenator PO2 somewhere between 100 and 200. Everybody with me with that concept so far? All right. And so, well, how do we do that? How do you know how much gas to go through each side? Do I need two Sechrist blenders and I got to sit there and try to figure it all out? No, you have to buy our quantum ventilation system and make sure you have that with our dual chamber oxy. By doing so, we've been able to automate the system to create the perfect environment to create a hypobaric state in the patient's blood. And we do that through actually saturation regulation. Our saturation monitoring is very accurate on the oxygenator side, and an oxygen post-oxy saturation of 97.5% yields a post-oxygenator PO2 of somewhere between 100 and 200 range based on the situation. There's no nitrogen given in there. So here you can see you'll have 3 liters of sweet blown through the main chamber. That's where most of the oxygenation and ventilation takes place. A reminder to the audience, our oxygenator doesn't have polyurethane heat exchange fibers in it, so everything you're looking at is all just polypropylene gas exchange fibers in these pictures. And then with that second chamber, sometimes it gets no ventilation, sometimes it just gets a little bit of ventilation, and at any time you can use it as a regular oxygenator and just blow equally through both chambers and use it as you normally would in an atmospheric state. The combination of our ventilation module with our quantum workstation gives you the capability to just, with a push of a button, go into hypobaric mode, and it'll automate the system to give the appropriate sweep. Both we can control it for CO2 as well as for the post-oxy saturation, and then it'll just automate controlling the amount of sweep through each chamber. So for those of you that are not familiar with our quantum ventilation system, we do have 2 sweep outports on the device. So you have a primary blend output, and then we have a secondary SCO2 saturation regulation port. So 2 separate sweep lines that are independently controlled going to 2 separate gas inlets on the oxygenator in order to achieve this state. This is a little video to show you. So for context, you're going to see the sweep up here in the left-hand corner. This SaO2 reg is in mils a minute, and it's showing you the amount of gas that's going through the second chamber as it's regulating that saturation to keep it around that 97 to 98% mark. So you can see that there's little to no gas going through it. We see the saturation here, it's 97. And as that falls, it's going to kick up the amount of gas that's going through that second chamber to try to get back to that 97. And it keeps the sweep constant, so it's just stealing some of this from the 5.6. It's not, this is not in addition to the 5.6. So that way your CO2 control remains constant. And so in looking at some of the studies, so we could look at what kind of impact this is, and also how our oxygenators were going to perform, not just in a hypobaric state, but just under regular circumstances. We did a lot of bench work with blowing a lot of air into the circuits and introducing that air so we could see how much impact we could have on mitigating gaseous microemboli. And this is under atmospheric conditions, so we're not even talking about hypobaric right now. We're just talking about basic oxygenator design in terms of which oxygenators can handle the most amount of air. And this is, we're the blue, the VT200, and then we looked at the Inspire and the AMG, which were orange and gray. And you can see even just under atmospheric conditions from some design standpoint with centrifugal inflow to the top of the oxy as well as outflow to the bottom, that we were able to mitigate the amount of air that was kind of passing through the system. Same thing here with our VT160. So we have 2 sizes, a 160 small adult and a 200 large adult. And here just comparing against the Inspire, and similar results with low to slightly lower ability to handle air as it's introduced to the oxy under atmospheric conditions, not even talking about hypobaric yet. When we add hypobaric to it, just looking at our oxy right here, we put 10 mils of air in under a hypobaric state, and you see that gets mitigated pretty good. You put a big slug of 30 mLs in there, you get a little bump, and then it's able to mitigate that downstream. Under atmospheric conditions, you put that big bump in, and it lasts for a while. So you definitely get a good impact on this side on the hypobaric state. Blue being post-oxy and the red line being 9 feet post-oxy. And so down here, this slide, this is the first two bars here are post-oxy hypobaric, and the second two bars are post-oxy atmospheric. So this is comparing hypobaric here from post-oxy to 9 feet post-oxy to atmospheric post-oxy, 9 feet post-oxy. So you can see the significant mitigation of the air from 10 ml injections as well as 30 ml injections, keeping in mind the scales are different on these two here. So this is 0, 20, 40 versus 0, 1, and 2 in terms of volume. So you get the idea, a hypobaric state seems to significantly mitigate the amount of GME that the oxygenator is seeing. So overall, just comparing post-oxy hypobaric and 9 feet post-oxy hypobaric, we see up to a 325% reduction in gaseous microemboli post-oxygenator and over 1,000 9 feet post-oxygenator, because again, it's not just the circuit that you're creating the hypobaric state in, it's all the blood that's circulating around, and it continues to reabsorb in the patient because you're creating that state in the patient as well. So I'll just continue on to talk about the hybrid system, and then we can take questions about both at the end, if that's okay. And so for Spectrum Medical, I think we're finally to the finish line where our full solution is coming to fruition. I'm going to speed it up a little bit because I'm running out of time. So I'm going to move through quickly this one. I think the reservoir is a little bit easier to move through than the oxygenator. So I'll review the current technology, talk about the limitations, and talk about our design with the hybrid system, and then the study that we did and the results of that study to show the benefits. On cardiopulmonary bypass, it's an artificial service. You get early contact activation, and one of the biggest problems is blood-to-air interface that wreaks a lot of havoc in our patients. Again, similar problem also with gaseous microemboli, which just increases that inflammation. And reservoirs can also have an impact on how much gaseous microemboli kind of gets through and into the system that the oxygenator has to handle. So the reservoir plays a role as well. I'll give a quick review of just hard shell, venous bag reservoir, and mini bypass. Traditional hard shell, which I think most people are using in this room, large to blood-air interface, dangerous to operate at low volumes, and inability to differentiate between cardiotomy and venous blood. The pros of the traditional hard shell reservoir are passive air removal, accurate blood volume indication, and integrated into your cardiotomy reservoir. So we fully acknowledge it's the most convenient way to pump on the market. A venous bag. Pros of a venous bag are it collapses to prevent gross air embolism. It mitigates the blood-to-air interface, and you have no embolization of antifoam A. But some of the cons are a longer time to set up, requires active air removal, does not incorporate a cardiotomy, vent and sucker bloods combined, and you also might need kinetic assist, which adds cost, complexity, and can contribute to gaseous microemboli. Mini bypass circuits or MEAC. I know it's not widely used in the US, but there are still some people using it in the US, and it's more widely used in Europe and overseas. Pros are lower prime volume and surface area compared to conventional, no embolization of antifoam A, and limited blood-to-air interface. Mini bypass circuits are complex to use, limited case types, takes a lot of orchestration between surgeon and anesthesia to pull it off effectively without risk. There's separate cardiotomy for vented blood and cell saver for sucker blood. Roller pump can't be used, and it's not ideal for myocardial protection. And looking at MEAC compared to conventional, a lot of studies looked at this. This was over a dozen studies, all of them kind of showing that MEAC had less inflammatory response, seemed to have some improved outcomes, but there was some caveat to that the commercially available integrated mini bypass systems required more specific training. They have a long, prolonged learning curve. They require teamwork and are more expensive than conventional CPB. So although MEAC seemed to have some clinical benefits, it certainly didn't hit the convenience mark. And so our goal was to say, okay, how can we make something that gives you the benefits of MEAC with some of the convenience of traditional hard shell reservoir? So we knew it had to be simple to use, have passive air handling, minimize blood air interface, be VAVD capable, separate handling of vent and sucker blood, minimal prime volume, and safe to operate at a low level. We combined the best traits of the hard shell, the soft shell, and mini into one system. This is the Spectrum Hybrid reservoir, minimum operating volume of 150 mLs with max of 4 liters. It has our phosphorylcholine coating on it, our PC1036, which all of our disposables are coated with. From an ease of use standpoint, you still get passive air and foam handling. It's a hard shell reservoir up top. You can apply vacuum to it the way you normally do now. Accurate level detection similar to your current hard shell reservoir. Integrated dual chamber cardiotomy, which is one of the differences we'll talk about with volume measurement, as well as positive and negative relief pressure valves. The key here is we talked about separated cardiotomy inlet. So during the case, you can separate your clean blood and dirty blood, vent blood and your venous blood come into the front chamber. There's a valve here, so if you want to keep that sucker blood separate, you can. If you don't want to keep the sucker blood separate, you can accept it and just have it, fill into the rest of the reservoir and use it the way you normally would. I know a lot of adult accounts are like, we rely on our sucker blood to keep flowing. So if that's the case, you can still do that with this reservoir, but there's a valve in there that you can turn, keep it separate, use it when you need it. If you do keep it separate, you have an option to send it to the cell saver mid-case if you need to use it and transfuse it back to the patient, or you can just trash it at the end of the case if you don't need it. The whole goal of this is about minimizing inflammation, right? There's a lot of activation that goes on from the blood to air interface, and we know that the sucker blood is already activated coming from the external chest, so that's why we're trying to keep that separate, trying to mitigate inflammation. I think the first thing everybody notices is what's that ball apparatus on the bottom of it. It's kind of like a better bladder. If those of you who remember the better bladder and Yehuda Tamari, who developed that, he was also contributed to the development of the hybrid technology that Spectrum adopted. And basically, it's just a collapsible bag inside a hard outer shell. And by doing that, the majority of the blood is in the bag while you're pumping the casein in the reservoir, and that way it's not being exposed to the blood-to-air interface. The bag is able to collapse down on the blood, mitigating that blood-to-air interface. Again, just looking at surface area, the blood-to-air interface contact, we're the red line down on the bottom compared to other hard shell reservoirs in the market. And you can see at 150, 500, 750, 1,000, and 1,500, the amount of our blood-air interface changes very little because the majority of that blood is in the bag. And just from an activation standpoint, kind of comparing the amount of blood-to-air interface, you can see at 150 mLs, we could have up to a 45% reduction in blood-to-air interface. You get up to a half a liter and up to 428%, and up to 1.5 liters, about 500%. Air handling in general, because the combination of the hybrid system along with the hypobaric oxygenator gives you like a double whammy in trying to mitigate blood-to-air interface. And the orange is introducing cardiotomy air at 500 cc's a minute. And just looking at the Spectrum Hybrid compared to other systems, and you can see it's able to handle air very well with the combination of the filters and the design. So we made sure we hit the mark that it's easy to use, combines the best qualities of the hard shell and bag reservoirs, significantly reduced blood-to-air interface with superior air handling. And this is a picture of, we did do a trial. Well, actually, I don't have a lot of time here, but I forgot I got to talk about the trial data. That's the most important part. So just about done. This was up in Kosalov in Istanbul, Turkey, where we did a trial of 60 patients with the hybrid system last year. And it was 60 patients, 20 hybrid, 20 MEAC, 20 conventional. These were just some of the logistics of the patients. All were around 60 years old. Most were men, similar body surface area and similar heart failure group. Again, 20 in each group, 3 plus or minus 1 anastomosis, just some of their bypass times and cross clamp times. Some of the bypass times on the hybrid system were a little lower than the others in that group. Compared to MEAC, that makes sense. But one of the things we found were just comparing the two systems, or the three systems rather, and I'm focused mostly on conventional. So the hybrid system, there seemed to be significantly less red blood cell transfusions, in the ICU, as well as platelet transfusions when compared to conventional over on this side. Looking at lactates, on bypass, 6 hours, 12 hours, and 24 hours, significant reduction compared to conventional, as well as creatinine levels. I have a graph here to show that. So here we're looking at lactates up top. Here's our hybrid system on this side. Here's MEAC here versus conventional here. And we're looking at creatinine here. A little bit more similar creatinine to MEAC, but definitely improved over conventional reservoir. The other big component of this in trying to wage war against inflammation, looking at interleukin 6, interleukin 8, TNF alpha, and oxidative stress. Too many blues in this color. I know I didn't put this slide together per se, but conventional is the darkest blue on the far right, and then hybrid is the medium blue in the middle. So you see conventional had the highest spikes in inflammatory markers all throughout, looking at all 4 markers of inflammation, whereas the hybrid system, which is second in the middle there, significantly improved over conventional and similar to MEAC, which is what we expected. To a bigger point from postoperative outcome standpoint, a significant reduction in mechanical ventilation, length of stay in the ICU, as well as hospital stay. And so in conclusion, fewer postoperative blood and platelet transfusions, improved biochemical parameters and inflammatory markers, shorter mechanical ventilation and ICU stay with the potential to improve patient outcomes by reducing complications and recovery time. Obviously, we need larger studies, for the future direction of this to get better information. And we're in the process of, working our way around the U.S. with our Spectrum partners in doing cases around the U.S., fully approved in the U.S. and out and in use in the U.S. now. And I always steal this from Jimmy Beck. He says you get good reviews if you're speaking at a conference and you give pictures of your family. So I always put that in there. It gets even better if you put your dog in there. And if you put both, then you get the best reviews possible. So I always end with that.
Thank you so much for a nice presentation. Any questions from the audience? Yep, we have a few in the back.
I can hear you.
No, you have to use a microphone, sorry, so the people online can hear you.
This is just a quick question. I was going to ask you, so when you have the modified quantum ventilation module, can you customize it to where you can still see your PaO2 on there as well? Because I noticed it kind of dropped off with that modification.
Yeah, you can use it as, if you're not in hypobaric mode, you can use it. When you're in hypobaric mode, you're going to be looking at saturation only at that time. It's not going to show you both. Yeah.
Thank you so much.
Thank you. I think all of this innovation is amazing. I really love the way Spectrum is going. I'm a big fan of Spectrum, so I'll get that out there in front, but that doesn't keep me from being critical. So my main question is around the hybrid system, which I think is a really great idea. 150 mLs is too much for peds, so when peds?
You always come with the best challenging questions. Right now, I don't have a timeline on that. Obviously, it'll be in development. I think you're going to have to, I think it's going to be a bit, yeah, just. Jeremy was supposed to give this talk, by the way, so I'm going to blame that one on him.
I'll chime in, Jim. I think, it is a lot of innovation for people to swallow, and, PEDS programs like yourself were early adopters of our technology. And, it would seem apropos that we would go with them first. But I think, the idea is to try and get, tow the adult peeps along and then, and then get there. But yeah, but hopefully we'll get there. Yeah, we have to look at bottom line things as well. But I did want to pose a question to Mark as well, in that, and this is kind of coming, I also work for Spectrum, career perfusionist, but if I were to need open heart surgery today, I would want physiologic oxygenation. I mean, it just seems so obvious. And I've seen the echoes on open heart procedures where there's just no air. It's unbelievable. And I think a lot of people don't get the idea that you're not creating this negative space and removing the air with the oxy. You're removing it in the whole patient, you know. So even if there's air in the heart after you've just done your MVR, whatever, the blood has that negative space. So any air bubbles are going to diffuse back into the liquid phase. That's the key thing to get a hold of. So my question is do you think this is going to be easily adaptable? And people are, obviously the Spectrum people could do it tomorrow, but you know, how about the other people?
Yeah, so it's a great question. And I think, you know, it's one of the reasons why I work for Spectrum, because we push the envelope. We can't push the envelope without our academic partners that are willing to collaborate with us and try to optimize care for their patients. It's a long road ahead, but I think you've seen the commitment by the company to continue to forge and blaze that path. We kind of know we're probably only catering to 20 to 30% of the market. And there's not many companies out there that are willing to focus so much energy and money to a small percentage of the market that's truly going to push the innovative side to try to optimize outcomes in patient care. But that's where Spectrum has lived from the beginning. And I think that's where they're going to continue to live. And that's kind of one of the goals of Steve Turner. So I think it will be hard to, I'll ask the group, who's comfortable with a post-oxygenator PO2 of 100? Keep going on your case. Who's going to want to turn their FiO2 up when you get that PO2 back? Right. So a lot of people are. So I think that's, we're butting against cultural norms that people have widely accepted and feel like things are good enough. I tell everybody all the time, we live in this space. You guys did all the big things. Okay. You can save everybody now. You do tremendous, amazing surgeries. You're fighting for a 1 to 3% improvement in post-op morbidity. While you're pumping your case, what are you going to do to try to help contribute to an improvement of 1 to 3% in post-op morbidity? And that's the lens that we have to get critical with now with ourselves to figure out how can we do that. Yeah, go ahead, Jim.
If it's a small one, because I want to be respectful to other people's time. Thank you. Thank you so much. A small one.
So just the hypobaric system, how it can impact the pressure drop of the oxygenator?
So it's our oxygenators are short path polymethylpentene, and so even though they're cylindrical and round, it's still short path. So the pressure drop is fairly low, and it shouldn't impact it. I think you just have to be condensation mindful, right? So sometimes if you're not sweeping through a chamber, you might get some condensation differences through the one chamber that's not getting as much ventilation as the other chamber. And so if you, I think that's something to be mindful of that could be managed with sweep or sighing. Good question.
Okay. Yeah. Thank you so much. Thank you so much, Mark.
Thank you.